There we go. So the things that I want to cover today, because this is a very large, extensive topic, so we're going to try to be very concise. But hopefully today we're going to talk about advocacy and kind of reflect on our relationship with what that means, learn how it shows up in childhood cancer, and then some tangible strategies and things that you can take home to your kids, even for kids who are not on treatment anymore. I think this is all still very relevant and important skills for everyone to have. So who am I? I'm Alexx. I am a certified child life specialist. I'm passionate about the areas of pediatric oncology, hospice, palliative care, grief and loss, and advocacy. I love spending time with my family and friends. I love spending time with my dog, Juno. I'm an avid reader, as we've discussed. I love my own version of carpool karaoke. My car time is my performance time, but also my unwinding time. I work in hospice full time, and I work in community hospice, and so I drive to families' houses. And so the time between families' homes or between office back to my house is my decompressing time, which usually involves either listening to audiobooks or singing, usually singing. I love plants, although since we've gotten our dog a couple of years ago, my plants have kind of taken a back seat. My green thumb has turned a little brown, but that's okay. And I'm also a childhood cancer survivor. So in its most basic form, what is advocacy? Because we know it's really, really big. It's huge. But in its most basic form, it's just receiving support from another person to help us express our hopes, our views, our wishes. So that's really at its most basic form what it is. But where it shows up in the childhood cancer world is kind of everywhere. And I've kind of broken it down into these 4 buckets. We've got the day-to-day advocacy. So that's exploring our personal preferences during treatment, procedures, things in our hospital room, our day-to-day speaking up, asking questions, and those sorts of things. If we zoom out a little bit from that, we're looking at asking questions about treatment, looking into other treatment options, asking for second opinions, being aware of appointments, follow-up protocols, and all those sorts of things. If we zoom out a little bit farther, we're looking at groups like OPAC and other advocacy groups and local organizations that provide peer support, connection, networking, and advocacy more locally. And then we zoom out even farther, and we've got the whole awareness initiative for something like childhood cancer. So we've got Go Gold in September, Childhood Cancer Awareness Month, advocating at like legislative levels, funding nationally for childhood cancer. So we've got all of these buckets, and they're all very different. But today we're focusing on this one. Today we are focusing on this one, the ones that are super actionable, relatively easy to do right away, and things that you can take home to your families and that you can hopefully share with other families that you work with. Well, so before I dive into that, I just want to go back to this for a second, because I'm not the expert in advocacy. I love the area of advocacy. As a child life specialist, I advocate for my patients and families every single day. As a childhood cancer survivor, I think I offer a unique perspective, but my job is to kind of merge these 2 experiences to be able to help us all think about advocacy in a way that's different. So for those that are listening to the recording later, you guys are the expert in your child's experience. And so while I'm here to provide some tips and strategies and hopefully to have a nice discussion and conversation about how we can look at this differently, I'm really not the expert. And so I just wanted to share that. I am going to share a little bit about my childhood cancer experience, which is something that I don't typically do in presentations, but I felt like this was the right one to do that, because I think it, again, merges my 2 experiences in a way that provides a good overview. So very quickly, I had leukemia. I had acute myeloblastic leukemia, or AML, in 2001. I was 8 years old, so you can do the math now, which is older than I like to admit. But I had AML, and so for AML treatment, I have no idea what the protocol is now, but back in 2001, the protocol was 8 months inpatient chemotherapy treatment. So I was treated at the Children's Hospital in London, which was 2 hours from my home. So I was inpatient at the hospital for 8 months. I went home a couple times when my counts were good enough, like for a weekend. But otherwise, I lived at the hospital for 8 months with my mom. I finished treatment in March 2002. And then I've been attending follow-ups ever, obviously getting farther and farther apart. So this is something that has stayed with me for my whole life, and yes, had a direct influence in my wanting to pursue child life. So I did want to introduce my experts, my mom and dad. And so I was talking to my colleague about this presentation, and I was like, I've never talked about this subject before. Like, I have no idea what to talk to anyone about. And she was like, you have so many great ideas, but wouldn't it be so cool if you could just have your parents come and like give the presentation? I was like, that's a great idea. So I called my mom and I said, hey, this is what I'm doing. I know you're not going to like come to Toronto because they still live in Windsor, Essex, but like, could you just give me like a list of some things that you've done that you like when you advocated for me when I was on treatment? She was like, yeah, sure. When do you need it for? I was like, Saturday. This was on Thursday. I had this conversation with her because I had not thought of this perspective at all, which is crazy. But my colleague was like, yeah, wouldn't it be so good if your parents could just like give the talk? And I was like, yeah, that would have been really smart. So my mom and dad pulled together this beautiful list. That's John and Alice and my sister Sam at the bottom. This was a picture of us at our Disney trip the summer I finished treatment. So these are some examples of how my parents advocated for me daily when I was at hospital. So starting right from diagnosis, they made sure that my oncologist was present for that conversation, just to ensure that if I had questions, they could be answered. They wanted me to know that like this wasn't just information that was coming from them, like this was official information that after all of these tests that you did, this is what has come of it. I was a notoriously difficult patient. And so before I got my central line put in, so for AML, I had so a line on the outside of my body instead of a port. And so before that got placed, I'm sure most of you are aware, we have to do blood work, and when you don't have a central line, you have to be poked. I was that kid. I was awful. And so they made sure that they were advocating for me every single day to make sure that it was a nurse who felt confident that was doing my blood work, that if we could, bunch blood work together, if I had an IV, can we take blood from the IV? So all of those kinds of things while the countdown was on for me to get the central line put in. I was also very bad at taking medication, very bad. Because I was admitted for my whole treatment, I was always hooked up to an IV. So they were constantly asking, can this be given through an IV? Can this be given through an injection? Can this be given when I had my NG tube? Can we just push it through NG? To really try to avoid me having to take oral medication because I was not good at it. Like I said, I did have an NG tube. And for those of you who have had a child who's had an NG tube, you know that it's a very challenging procedure. And so one of the things that they advocated for was ensuring that child life was present for all of my NG tube cases where possible. I also was very, very nauseous on chemotherapy. And so I would throw up and then my NG tube would come out. And so if that happened in like the middle of the night, we would ask, can we wait until child life is in the morning, let her sleep without it, put it back in the morning. So they were constantly asking, like, we know we have to do these things. How can we do it in a way that's better for Alexx? One of the recommendations after I finished treatment was that my Hickman line stay in for X amount of time, just in case. And my parents were very adamant on no, we wanted to come out right away. Because with the central line on the outside of your body, it's unlike a port, you can't swim, you can't bathe, you can't get it wet. And so going into summer, my parents really, really wanted us to be able to have a nice quote unquote normal summer where I could swim, where I could take showers, I could run on the sprinkler. I didn't have to be so cautious about it getting tugged. And so my parents are basically like, we'll take it out and we'll deal with whatever consequences come. If we have to put it back in, we put it back in. Knock on wood, we never had to put it back in. I've been cancer-free since 2002. They also, while I was on treatment, asked for me to meet with the child psychologist at the hospital because they wanted to ensure that I had a safe place to talk about my privately without worrying about hurting their feelings or upsetting them. So those are just some of the ways that my parents advocated for me while I was on treatment. And I'm not sharing this to be like, if you haven't done these things or you didn't do these things, that you're doing something wrong. It's just to give you examples of ways that even back in 2001, cancer treatments and the whole process looked very different, how my parents were trying to stick up for me and make sure that my voice was being heard. So when I was starting to gather information for this, to figure out how do we take this really big topic and make it concise and relevant, this kept coming up, this whole thing about consent. So I'm not going to talk about it for too long because it's really boring. But I do think it's important because the Canadian Pediatric Society actually has a full position statement on consent in pediatrics. It's called Consent in Pediatrics. Actually, no, it's called Medical Decision Making in Pediatrics from Infancy to Adolescence. So it's all the way from the moment you're born until you graduate pediatric care. And so there actually is no age of consent in Canada for medical decision making. But obviously that comes with some stipulations because we don't want, 5-year-olds making life-saving, life-altering decisions based on their medical care. But this part of the position statement really stood out to me because it talks about a family-centered shared decision-making model that best respects and supports the emerging capacity of the pediatric patient, as well as the parental authority and the healthcare professional. So it takes all three of those pieces into consideration, but the patient is the first one that's listed. The participation of children and adolescents in medical decision-making should always be sought, and their involvement should be proportionate with their capacity and circumstances. So again, what we're asking a 17-year-old to make decisions on is not the same thing we're asking a 4-year-old to make decisions on, but that does not mean that the 4-year-old should not have buy-in into what's going on or not be uninformed about what's going on. Their consent, assent, or dissent must be respected whenever possible. So one could argue that the participation of children and adolescents is not always sought in medical decision making. And again, there is definitely a fine balance because again, we don't want to leave big life-changing decisions in the hands of 7-year-olds, but there are certain things that they do have a say in. So that's why I thought this piece was really important to highlight because it is something that is highlighted, is documented, and there is no age of consent for a reason because we want all patients to have some level of autonomy in a way that makes sense for them, their age, their developmental capacity, and those sorts of things. So what decisions can they make? So in some cases, and I would argue in most cases, if not all, patients have a say in all of these areas and then some. So I started with needle-related procedures because those tend to be the things that are the biggest, the scariest, the hardest, the things that kids stress out about the most, at least like most ongoing. So whether that's finger pokes, something so small and that should be so quick, arm pokes, lumbar punctures, anything else involving a needle, vaccines, any sort of IM injection. These are all the things that they can choose. Do they want to sit up? Do they want to lay down? Do they want to comfort positions? Do they want to be sitting on your lap? Do they want you to be holding them? Do they want you to be beside them? Do they want you to be out of the room? Some of my teenagers are like, Mom, you need to go. Do they want numbing cream, freezing spray, Buzzy Bee, or any other topical anesthetic to numb the area before their poke? Do they want to watch? Do they not want to watch? Do they want to count or do they not want to count? We don't want to give them the option of counting to 100, but do they want to count to 3 or do they want to count to 5? For things like flushing central lines, do they want the flush fast or slow? Do they want to push the flush themselves? Like they're allowed. Distraction item choices and one voice. One voice is my favorite thing as a child life specialist, and that is essentially assigning one person to speak during a medical procedure aside from the patient. So that could be mom, that could be the nurse, that could be dad, that could be sibling. Oftentimes it's child life because we are the ones that have made the coping plan with the child and we're coaching them through step by step. But rather than having 4 different people saying, you're okay, we're almost done, you're so close, you're doing so well. Meanwhile, the child's absolutely freaking out and there's 10 people shouting that I'm okay. It's one person calmly walking them through, letting them know what's happening in whatever way they've agreed upon, coaching them through their deep breathing, encouraging them to follow the distraction, all of those sorts of things. So it's really kind of taking everything down in a situation that the child might already be really heightened. For imaging and other procedures, a lot of the same things, but especially something like parental presence. The policies on parental presence for different procedures really depends on the hospital. So this could be anything from surgery to going in for spinal taps to bone marrow aspirations. Some hospitals allow it, some hospitals don't. If they don't, can we look at child life being present instead, or another staff member that your child is really comfortable with? age-appropriate preparation in whatever way that looks like for your child. This also means the timing of the preparation. So if your child has explicitly stated, I don't want to know about my blood work until like the nurse is like outside the door, then that's no problem. My job as a child life specialist is to say, based on your child's age and what I know, this is when would be best if you have no idea when to prepare your child for a procedure. Unless your child has this explicitly stated otherwise. If they say, no, I want to know as soon as you know, then you let them know as soon as you know, and we will deal with whatever consequences come from that. Bringing a comfort item, of course, distraction items, of course, and one voice also applies in this scenario. Medications. It's the bane of my existence when I was on treatment. I was just so bad at it. But like, these are some things that you can ask questions about. Does it need to be given orally? Can it be given in an IV? Can we do it in an injection? Can we do it in a liquid form instead of a tablet form, or vice versa? Why does it have to taste bad? Can we put it in something? I experimented with so many. I did peanut butter, I did apple juice, I did chocolate syrup, I did jam, a variety of jams. I did. The one that really stuck for me was chocolate ice cream. I cannot eat chocolate ice cream to this day, but it is okay because it is 2024 and there are so many other options out there. So it is okay. It was a sacrifice I was glad I made. Even with medications, one thing that I learned when I was working in pediatric oncology was kids who, let's say, need multiple pills of something and they're small enough. If the issue is really the quantity and not the actual act of swallowing pills, can you fit all of those little pills into one empty capsule and just have them take one pill instead? I know, right? I know, exactly. It blew my mind also. I was like, that's brilliant. So if taking 5 pills is the issue, but your kid can handle 1 or 2, just merge them together. So all of these different things we can consider. The hospital environment, especially if you're in for multiple days, weeks, months, like I was, how can we adapt this environment to really suit what I need to feel comfortable? So the lighting, my bedding, I brought pillows, I brought blankets. I was there for 8 months. We moved in. I've seen people moved in being admitted for a weekend. So you can imagine 8 months we moved in. But can they decorate their room? Can they put stuff up on the wall? What kinds of sound? What is the ambience of the room? Should it be like? One of the biggest things, and when I used to do presentations for med students, one of the biggest things I would remind them is please knock before you enter a patient's room. And this is something that I find staff often forget about just in the hustle and bustle and in the day-to-day, especially if a patient is admitted to the hospital for a long time, because you get so comfortable with them. But at the end of the day, the patient's room should be treated as their home, as their bedroom. And you always need to knock before entering. So if that's a matter of putting a big sign on the door saying, please knock before entering, and reminding people to, if they don't, then do that. This could be anyone from volunteers to cleaning staff to porters that are coming to pick you up for a procedure. Anyone, they should be knocking before entering the space. And that also helps to keep the space private rather than feeling like you're an exhibit. People can just come and go as they please. We want that space to feel really safe. Another thing is you can find out at the hospital if there's a treatment room that can be used instead of doing simple procedures at bedside. So if your child is really struggling with something like blood work and they're constantly coming to the room to do it, you can ask if there's a treatment room and ask that all procedures be done in the treatment room. Not vitals and small things like taking temperatures, but anything that would be considered a medical procedure. You can do them outside of the room. They don't have to be done at bedside if there is a treatment room or another room that they can be done in. It is actually also best practice that it be done that way. Just saying. So when I, again, was doing research for this, I came across this model called the CARE model. And I had never heard of it before. And I've been doing child life for almost 10 years. And it's really, really simple. And it's not just for childhood cancer, but it's for all healthcare settings, all healthcare experiences. And it can be used in adults as well. So CARE is choice, agenda, resilience, and emotion. So all of the things we just talked about are kind of off of letter C, choice. And offering these choice, we're giving kids power in an environment where they feel really powerless. I think it's safe to say that all of us who have experienced really any sort of life-changing diagnosis, cancer or otherwise, you feel powerless at least for a little bit, if not the whole time. So by offering these really little choices, we're giving some of that power back, not just to the kids, but to the family as well. So by following these principles, we are reducing any sort of lasting trauma. That's not to say that by following all these things, you will come out completely unscarred from childhood cancer. As someone who, you saw my small list of ways my parents advocated for me, I still cannot say like that childhood cancer did not have an impact on me, because it did. And so even though I'm still, some would say, scarred from childhood cancer, that doesn't mean that my parents didn't do a good enough job advocating for me. It just means that cancer is really, and so even though I think as parents, sometimes there's the, am I doing good enough? Should I have asked for this? That could have gone better. It's really just that cancer is really hard, not that you didn't advocate hard enough. So moving from choice, we look at agenda. And this one really stood out to me because yes, it's the knowing what to expect, but also knowing what is expected of the patient. And so yes, we want to make sure that kids are prepared for their procedures, but as a patient, I also need to know what is expected of me. And so in child life, we really love to suggest that kids are given jobs. So, you know, if holding really still needs to be the job, then holding really still is the job. But in order for me to hold still as a patient who's really scared, I need to ensure that you're listening to the plan and the choices that I made. So it ties back into C, choice. If I've said that I am really scared that it's going to hurt and you didn't put EMLA on my arm before you came in to do the poke, how am I expected to do my job of holding still for the procedure? So yes, I know what the steps are. I know because Alexx showed me what the steps are for blood work. But if not everyone on the team did their job, and my thing is that I'm really scared that it's going to hurt and I don't have EMLA on my arm before you came in to do the poke, then how can I be expected to do my job? So it's completely reciprocal, that by giving the patient a choice is one thing, but if we're not following through on that choice and we're still expecting them to do what we've said is their job, then how is that fair? So yes, it's good that the kids know what to expect of the procedure, but they also need to know what to expect of themselves. But in order to meet that expectation, sometimes they need help. So that's making sure that, you know, my mom is present. Don't come into my room, even if it's something as simple as getting blood pressure done. For kids who have really deep medical trauma, getting something like blood pressure can be really scary. And so, yeah, mom stepped out. In my parents' case, it was usually stepped out for a quick smoke break back in 2001. But even though they stepped out to do that, if I'm freaking out about the blood pressure, you can wait until my mom comes back and come back and do it. Right? But in order to know those things, we need to say what our child wants, but then we also need to rely on the medical staff to follow through. So it's completely reciprocal. Resilience, I really like that this was included in there because it talks about highlighting strengths and also reframing the negatives. So not negating that the negatives happened. Like for me, was I kicking and screaming and should I probably not have been? Yeah. Were my parents, you know, yelling at me saying you should have been holding still, otherwise that would have gone so much easier? No. We want to say things like, I know it was really hard for you to hold. And you know what? We had a choice this time of you sitting on my lap, but maybe that didn't work. So what choice can we make next time? So that way you can do your job of holding still. So they're all kind of interconnected to each other. And then the emotion. If you've got people gowned up coming in with needles into your room, like that's inherently scary. It's inherently a scary experience. So recognizing and validating, like, yes, that's scary. Just because I have an expectation to sit for this procedure doesn't mean that I can't be worried about it. And so normalizing and validating that the fears and the emotions you're experiencing are normal. And I'm feeling this way too. But if we rewind and we go back to our choices and our agenda, how can we ensure that we get through this together, even though we're feeling scared? So I thought this was a really, really neat model that I wanted to share because it really ties in together all of the things that we talk about and we encourage all of it. Okay, so some tips. And these seem really basic, but I think they're things that often get overlooked. So I have found in my experience that pediatric professionals are usually really good at talking to the patient, but sometimes they forget. And so even if the doctor seems like they're in a rush and they're trying to get through things, it's okay to encourage that they rewind and that the questions be directed to your child. or you repeat what was said to you, turn to your child, and say it to your child, and let them reply. Because this is, if we're going back to the consent, this is about them. This is not about you. This is not about your experience. This is about their experience. And so if the physician or if the nurse or whoever you're speaking with has not directed something to the child that should have been directed to the child, it's okay to take that information and then repeat it and allow your child the opportunity to respond. That also means that you can rephrase things that are posed by the medical team if your kid does not understand, rather than answering on their behalf. So even things like as simple as, Mom, were they feeling constipated after that medication? You could say no or yes. Or you can say, constipated is when you're having trouble pooping. Do you feel like you've had trouble pooping? And they would know if they've had trouble pooping. So let them explain. And then you can ad lib, you can add commentary, but it's their body. They're the ones that the questions are being asked about. If you want to know what was their urine output last night? Mom, here's the sheet, but also, honey, can you read that number there? Because she wants to know how much you peed. Yeah, it says 22 or whatever. Let them participate. It's their body that they're asking questions about. So just because they don't understand what constipated means, we can turn and we can say, constipated means when you're having trouble pooping. Do you feel like you've had trouble pooping? Rather than saying, no, like they're fine. Or yeah, it's been a little bit difficult. Let them explain it. Allow them to explain their symptoms or concerns in language that feels most accurate to them. So this one's really important because I think we see kids playing, or I've had families who've been on outpatient treatment and their kid, went to camp or was out at recess having so much fun. And then they came home and they were like, yeah, my leg was really hurting at school today. And they're like, really? You didn't seem like your leg was really hurting at school today. But if they're saying their leg was really hurting, we need to believe that their leg was really hurting. If the doctor's asking, how's your, have your headaches been? And you say, oh yeah, I've been having headaches. And the parent goes, you didn't tell me you were having headaches. That doesn't mean that their headaches aren't happening. And so rather than assuming that we know everything our child is feeling, we want to allow them to explain in a way that makes sense. We can add on and say, they didn't tell me this, or, this is how they described it before, to give them a full picture. But to allow your child the opportunity to think, okay, what am I feeling in my own body right now? And how would I describe that? Is such an important skill to have just in life in general, to be able to describe to a medical professional, how does that feel in my body? Or how would I describe this as shooting, as burning, as stinging, as sharp? To be able to have that vocabulary and to be able to share those things confidently with your medical team is just an important skill. And so we don't want to take that away from our child. We want to encourage them to use their own voice and be able to describe these things. But again, we can add a little bit if we're not entirely sure, or maybe the doctor's not quite understanding how. And then we want to reinforce plans with the medical team that your child has shared. So if you made a plan for blood work, for surgery, for something as simple as vitals, anything at all, you want to make sure that it is being reinforced to all of the medical professionals. It doesn't matter how many times you have to say it or who you have to say it to, but you want to make sure that it is being reinforced to everyone. Because it's one thing to come up with the plan and to make all these choices. If not everyone knows about it, it's not going to work. And so it doesn't matter if you need to print it off and ask them to put it in the chart, make it official, put it on the door, plaster it on the whiteboard, wherever, put it everywhere. Because if not everyone knows about it, then it's not going to be followed through. And then your advocacy is not going to go anywhere. So my Bitmoji here is how I feel about barriers to advocacy in general. So these are some things that I think we've all probably experienced. So working with medical staff who don't listen or who don't follow the plan, who come off as they're in a rush. We can't do it that way because they don't have a lot of time. Clinic's really busy today. Doesn't matter. Doesn't matter. We are all human. So going to my professional side of things, it does happen. We do become in a rush. We do have really hard days. We do have situations where we feel like this is going to take a really long time and I really don't have time. If I'm looking at my patient side of things, I say, who cares? This is my journey and I want you to do these things. Again, going back to expectation, I'm doing what is expected of me. So I need you to do what's expected of you, which is to listen, to take your time, and to follow the plan that we've laid out. A lot of people, again, this is my child life specialist hat, will say that things can't be done stating hospital policy. What I say to that is policy can be changed. And that's a larger conversation than we can have in this presentation, which is why I'm focusing on the day today. But there are certain things, as long as they are safe and as long as they are based on evidence, fun fact, all of the things I've suggested are, as long as they are not outrageous and reasonable, hospital policy can be changed, and it should be changed to suit the needs of the patient. So again, larger presentation, larger discussion, but that is a barrier where they say, we don't do that here, or we've never done it this way, or we can't because it's hospital policy. Policies can be changed. I'm gonna leave that at that. There is this connection between advocate and difficult, and not wanting to be that family or that mom or that dad or that patient or that room. But quite frankly, the people that are giving those labels and placing those labels are the people that have the problem. And so sometimes I have families that, would say to me, like, I don't want to ask that, or I don't want to say that because I don't want to be that mom, like I don't want to come across as being difficult, right? And I would say to them, either A, I can do it on your behalf, or like, just do it anyway. What you're asking for is not outrageous. What you're asking for is not crazy. So just ask, be that person, because the issue is not with you. The issue is with the medical system and the way that we view those kinds of people or those kinds of requests. And again, if what you're asking for is not outside of the realm of like complete possibility, then ask for it, demand it. This is your child, demand better for them. And your child will also see that as an example for things that they can do to advocate for themselves. And most importantly, you don't know what you don't know. What don't we know? We don't know a lot of stuff. Ask about all the things, ask multiple times. I've had families so many times who feel so badly for repeating themselves. I'm sorry, what is your name again? Or what is it? Oh, child life all the time. Sorry, what is it that you do? What is your job again? It's okay. You've met hundreds of people. You are at your peak of memory storage. You need to focus on your child. Ask as many times as you need to. Write it down everywhere. I don't care. Do whatever you need to do to get the information that you need. There are so many groups like OPAC and like other groups that can help and guide you through this process, but that doesn't mean that everyone knows everything about everything. There are so many things that we don't know or don't know that we're allowed to do unless someone tells us. We need to be able to ask those things, especially for families who are in the hospital for a long period of time. Get to know other families if you're open to it. Ask staff, like, what are they doing in that room over there? I saw a sign on my neighbor's door saying, like, please knock before entering, or like, no vitals between 1 and 2 because my kid's sleeping. Like, can I do that? Yeah, you can. You know who goes into all the rooms? Volunteers. It's like, I live in a townhouse, and so I'm constantly asking my neighbors, like, how did you guys arrange that closet on the second floor? Ask other parents, what did they do in that room? Because they've been here a long time. What did they do to make it better? How did they organize their shelf? What did they put in their mini fridge? Ask, because we're trying to make this marginally better, an awful situation, just a teeny bit better. And the way to do that is by fostering a community and growing your network of people who are there to support you, and just ask the silly questions. There are, in my opinion, no silly questions when it comes to cancer. So lastly, how can we help our kids to use their voice? Write it down. I think I got it from my mom. I still have my binder of like all of my counts, all of my everything from when I was on treatment. Everyone's phone numbers, everyone's extensions, email addresses, everything. Write it down. Write down even the unserious things. So I have had so many instances of like parents talking to me as if like I'm the most important person they've ever talked to. And like, we cannot talk about, first of all, I'm a child life specialist. We can talk about silly things as long as you want. But parents that, will apologize. I'm sorry, don't listen to them. Or like they don't know what it's okay. and kind of brushing off because their kid wants to know what my favorite ice cream is. If you need to know what my favorite ice cream is, that is the most important question, and that I will answer it. Or whether it's to your oncologist who is maybe a little stuffier than you would like them to be. If your kid needs to know, do you have a dog? That's the most important question. Let them build the skills of having this confidence of talking to their medical professional. Don't silence their silly commentary. If your kid needs to make fart noises in the middle of a diagnosis disclosure conversation, let them remember that, yeah, they told me I had cancer, but then I went, who cares? This is their experience. And if they need to cope with it in a way that is a little bit different, or in a way that us as adults wouldn't, who cares? Plan everything, all the things: blood work, finger pokes, arm pokes, port accesses, D accesses, dressing changes, pill swallowing, procedures, spinal taps. Make everything official. Have it all written down on a piece of paper. Have a book. We're coming in for blood work. One sec. Okay, so this is what we're going to do. Have it all written down. Put it in the chart. Put it on the door. Put it on the walls. So that way every single person that comes in the room, or every single person that comes to greet your child, knows, oh, this was the chart that I read that said you need EMLA. Before I do anything, I'm going to go get that. This is the kid whose chart I read that said they don't like to have their blood pressure done on their arm. They need it to be done on their leg. Or that needs to have their hospital ID on their ankle instead of on their wrist because it's too overwhelming for them to have it on their wrist. All of those things are so small, but so important to know in the grand scheme of things. So that's all I have for you guys today. Because I could have kept going on and on about this topic because I think it's so important. But I didn't want to overwhelm, and I didn't want to get into areas that are so much larger than the day-to-day. So I welcome questions. I welcome discussion. For anyone that's watching the recording later, you can reach out to me anytime. Yeah. Thank you. I guess I'll keep the recording going in case anyone has any questions or anything.
I have a question, Alexx. Can you hear me?
Yeah. Where are you? Hold on a sec. I can't see you, but oh, there you are. Hi, Karen.
Hi, I can't see me here, but I there we go.
There we go. Hi.
Hi, how are you?
Hey, how are you?
Good. Thank you for that presentation. It was wonderful.
Thank you.
My question is just based on the last piece you were talking about on the coping plans.
Mhm.
It's been a while, thankfully, that I've been in the hospital, but we eventually got to that place where we learned from our mistakes with my son in terms of what he needed and what he didn't need around procedures and those kinds of things. So it would have been awesome to have, when we first walked in, some coping plans handed to us, and then we would have had a thought about, okay, what are the steps that are going to help him as we go? Is that something that is provided by Child Life now, or do you know?
So theoretically, so it's hard because at the start of the diagnosis, you're so overwhelmed with information that, like, theoretic, like in an ideal world, every child would meet the child life specialist and they would be able to go over all of these things. One of the things that's really hard is that, you know, we'll introduce ourselves and introduce our role and say, these are things we can help with. If your child has trouble with needles, these are some things we can help with. But until, like, while you're digesting all of this new information, that often gets put like in this other place because the, oh my God, my kid has cancer is so
yeah, exactly.
And so unfortunately, I find that Child Life teams are also so small that, you know, sometimes it takes a few instances of like, wow, this procedure is getting harder and harder, not easier. How are we supposed to do this for, you know, 8 months or a couple of years? Like, how are we supposed to do this? And then Child Life is called to be like, okay, let's figure this out and let's make a coping plan and let's do this better for your child. So it really is, I think, one of those things where I don't know if it's something that could be changed right off the bat. I think it's more like groups like this who meet families for the first time who are like newly diagnosed and providing those tips right up front to be like, you know, how does your kid do with, you know, blood work or port accesses or whatever? Like, oh, they're struggling. Okay, I'm going to tell you, just reach out to Child Life. Don't say anything else. Just reach out to Child Life. They will help you come up with a plan to make that better. So it's kind of a bigger system issue. And again, you don't know to advocate for it because you don't know that exists. Like we don't know what we don't know. So I think having groups like OPAC and other groups that meet families who are newly diagnosed and kind of planting those seeds of wisdom kind of early on without overwhelming them. So saying like, you know, reach out to the social worker because they really helped me like fill out forms that I needed for work. Rather than being like, we did this and we did this and we did this and we did this, just saying, connect with your social worker and then let the social worker do all the things. Or your child's really struggling to swallow pills or to have blood work done, just connect with Child Life. And kind of just leave it at that. Because until I think we get to a place where it's like a mandatory, you meet the social worker, you meet the child life specialist, you meet the dietitian, et cetera, you're not going to know those things unless you've already been in this, on this side of it.
Yeah. And yes, and parents learn by doing. And I'm just thinking about our drop-in and the kinds of things that parents talk about. They might just give us an overarching statement like today was a bad day, but maybe won't give us in detail, you know, my child was jumping up and down and they couldn't do a blood draw or whatever. So this is something that I'm going to take with me for those kinds of discussions to ask a few more questions. But then let's say they are going to be able to articulate certain things that they've learned that their child responds well to. Would we, when you're saying put it on paper and like slap it up on the wall in the room or whatever, is there something that you know of that's a bit more formal that they can give to their team?
So it's going to depend on the hospital. I know some of the larger children's hospitals, like if they have like a comfort promise or commitment to comfort, like across the hospital, they might actually have a form. But there are some other things. There's the Meg Foundation for Pain. You can actually print off a coping plan and like it's like a checklist, and you can say like I know when I worked in the Pogo clinic, like if I had something where like we knew this kid needed a private space, we knew that, you know, they were really overwhelmed or they needed only, you know, Lindsay to do their whatever, I would write it down and I would physically put it on the front of the binder. So anyone covering clinic knew that, okay, Alexx wrote something. I need to read it or she'll get mad at me. They knew. So you can just say, can this go in their chart? Even if it's an electronic chart, can this go somewhere that people are going to see it? Like it can just be a Word document. It can just be an email. Like, can I type this up for you in an email? And can you make sure this goes in their chart so people can see it? Even if there's not like a formal way to do it. Because sometimes there's not. Which is, again, goes down to policy and advocating for all of those kinds of things. But parents can just say, like, I wrote everything down that we did today that worked. Can you put this somewhere where everyone will see it?
Great.
Thanks.
Thank you.
Thank you. Anyone else have any questions or anything? Yeah. Can you hear that, Karen?
No.
Okay. So advocating for kids who are too young to be able to verbalize or who can't or don't communicate verbally. And I say can't or don't because I've had a couple kids who can and who supposedly are really talkative. And they come to the hospital. I'm like, I don't even know what your voice is like. And so those kids definitely require a little more TLC. Kids who either don't have the developmental skill, like we're talking babies, we're talking toddlers who can't articulate. And then we're also talking about kids who cognitively or developmentally either just don't have that skill or they communicate differently. And maybe as mom, you know that like when they're shaking their arm, it means they're in pain. Whereas like to me, they're just shaking their arm. So I will often ask parents, and this is coming from me as a professional, I know as a child life specialist to ask these things. Some professionals don't. And so I think it's important that, and I think as a parent who does have a child who has a disability or has some other cognitive impairment or physical impairment, I think you learn that skill very quickly on how to advocate for your child and explain what it is that they need or what it is that they're trying to say. And I do recognize that it becomes very exhausting because it's just you advocating for them because they can't advocate for themselves. But I think it's even more important and even more valuable to share with the team. I know this to be true because I see my child every day and I am the expert on my child. So it's taking both of those things and combining them. So like for me in child life, yes, I have knowledge in child development. Yes, I know how a typically developing 2-year-old is going to react to being in the hospital for 2 days. Yes, I know when should theoretically be best to prepare this 5-year-old for surgery. But what I do is I take this knowledge and then I have to apply it to your unique child, right? And the same is true for kids who have developmental delays, disabilities, cognitive impairments, different sorts of delays, whether it is impairing their speech, their ability to articulate, communicate, whatever it might be. And so the advocacy looks a little bit different, but is equally, if not more important, because they are going to have to you are going to have to advocate for them for much longer as well in the medical system. And so I think learning early on, especially in treatment, what works well will only serve you well as a family. And again, putting those things in the medical chart, put them everywhere. Put them everywhere. If he's screaming, that means he's happy. Like, it's good for us to know these things, right? Or if you, turn the lights on too bright, they might run out of the room. Like, these are important things to know, but not only is it important for us to know because we don't want our patient running away, but it's important for us to know because we don't want them to be scared and not want to come back. I think a lot in terms of like staff comfort and knowledge on how to support patients who have communication differences or who aren't able to communicate verbally. That's something that really is like a larger conversation of, I think we do a disservice in medicine of, not being educated in how to provide support to all different kinds of people with all different kinds of abilities and capabilities. So I think, again, ensuring that child life is involved early on because we do have the training to be like, yes, I know how a typically developing 5-year-old responds in the hospital, but I also have the knowledge to know how a 5-year-old with XYZ who's experienced ABC is going to respond in the hospital. And I know to then ask you, what was the most recent experience like for you? I know what questions to then ask you to be able to combine that experience where a lot of other professionals may not. So it's, again, we don't know what we don't know until we know. Anything else? Okay, great. Thanks. Bye, Karen.
Bye. Thanks, Alex.